Hello everyone, today we'll speak about cystic fibrosis. So cystic fibrosis is an autosomal recessive disorder and is common in European descent. It is caused by a mutation in the CFTR gene, which encodes for the CFTR protein. These mutations result in a defective chloride channels. This disease can cause meconium ileus, failure to thrive, which is failure to grow normally, malabsorption later in life, and later in life they will have some recurrent respiratory infection and some problem in pancreas and infertility. So, what is a meconium ileus? So, it is an intestinal obstruction caused by a failure to pass meconium, which is the stool in the first 3 days in the newborn. Typically manifest in the first 3 days of life with abdominal distension. It is associated with cystic fibrosis in 90% of the cases. It can get diagnosed from an X-ray. So this is an X-ray of meconium ileus. So, as the disease progresses, defective Cl channels in the respiratory tract result in thickened bronchial mucus and impaired mucociliary clearance. So this will lead to chronic respiratory infections, pulmonary colonization, and bacterial infections. And we will have a decline in the lung function. Patients often experience acute episode of worsening respiratory symptoms, which is called as pulmonary exacerbations. CFTR dysfunction will also cause problems in the pancreas and the liver. So in the pancreas, it will cause us CF-related diabetes, and in the liver, we will have CF-related disease. So if CF is suspected, we will do a couple of tests, like for example a sweat test, a genetic testing, and a CFTR physiologic testing. Patient with CF should be managed at a CF-associated center. In these centers, we will have a couple of specialists because CF can do diseases in a couple systems, more than one system, so we will need more than one specialist to treat it. So, many patients also benefit from a new type of drugs called CFTR modulators, which can partially restore the CFTR function. And the life expectancy for cystic fibrosis disease is 45 years. And usually the cause of death is from lung disease. For the epidemiology, is the second most genetic metabolic disorders in individuals in Northern European descent after the hemochromatosis. And the incidence in the US, for example, is 1 to 3,500, which is not very rare, to be honest, it's common. Etiology. As we mentioned, it's a hereditary disease, it's genetic from an autosomal recessive disorder. As if you are studying genetics right now, so CFTR gene is located on the long arm of the chromosome 7. And these are some information about genetics, like the most common mutation, you can rate them. And this is just an example for the hereditary thing. So if the parents are heterozygous carriers, like they just carry the gene, they don't present it, they don't have cystic fibrosis, but they carry it, the children will have a 25 chance of getting it. So this is heterozygous. X is normal, S is let's say that is a carrier, so it's recessive, so it's not present. So when they mate, we will get a complete normal one, a carrier, and one with cystic fibrosis, so it's 25%. Pathophysiology. So, general considerations. We mentioned that the CFTR gene encodes for the CFTR protein, which is important in the chloride channels. So, a mutated gene will give us misfolded protein and eventually absence of the chloride channel. This will cause problems in the respiratory epithelia, sweaty glands, pancreas, and liver, and reproductive also. So on the sweaty glands, we will have a defective channel, so this will give us an ability to reabsorb the C from the lumen, and this will result in reduced reabsorption of sodium and water and excessive loss of salts. So we will have elevated levels of NaCl in sweat. So this is, for example, this is the normal case. We have the CFTR gene that will give us the Cl channel. The Cl will go outside, the Na will come inside in the gradient. Here, what we will have cystic fibrosis, this is not working. So Cl will accumulate here, Na will accumulate here. This will disrupt the transition function, and they will combine and cause result in NaCl. So for the exocrine glands, chloride channels are responsible for transporting Cl. We have a defective in the chloride channel inability to transport Cl. This will result in the reduced secretion of Cl, and H2O, the water, will accumulate in the intercellular. Also, they will accumulate, as we saw in the picture. Na accumulated, Cl accumulated, water accumulated. This will result in a hyperviscous mucus, will accumulation of secretions in the, and it will block the small passages. So we'll have a chronic inflammation and remodeling and organ damage. So the clinical features, as we mentioned, we will have meconium ileus, we will have failure to thrive, pancreatic diseases like pancreatitis, pancreatic insufficiency, we will have fatty stool, malabsorption, abdominal distension, diarrhea, hypoproteinemia, and deficiency of fat-soluble vitamins. For the CF-related, we will get also CF-related diabetes, as we mentioned, level of bile duct abnormalities, cholecystolithiasis, cholecystitis, and we will get all of those. We will get intestinal obstructions, as we mentioned. We will have meconium ileus and rectal prolapse. It's rare, but it can happen. This is a rectal prolapse. The intestine will come outside. For the respiratory problems, we will also have obstructive lung disease with bronchiectasis, chronic sinusitis, and nasal polyps will eventually develop. We will have some infections in the respiratory system that are recurrent. We will also have a barrel shape, and we will hear moisturials that are indicate pneumonia. And we will see, because of the chronic respiratory insufficiency, we'll see a digital clumping. So nasal polyps, let's speak about them a little bit. They are, it is a benign lesions of the nasal mucosa or paranasal sinuses due to a chronic mucosal inflammation. Typically present with postnasal drip, bilateral nasal obstruction, and impaired olfactory function. So this nasal polyps do not decrease in size following therapy with nasal decongestants. So let's see some picture. So do you see all this place? Wait, let me bring the laser. So do you see all this place? It should be all dark. So we see now this is not dark. So these are nasal polyps. So if we highlight them, all these. Guess where it is in this picture? Yes, all this should be black. All this should be black. So we have it again. So sweaty glands we will have a salty sweat, possible electrolyte wasting. For musculoskeletal, we have frequent fractures due to the osteopenia. We will have kyphoscoliosis. For the urinary system, we will have nephrolithiasis and urinary tract infections. For the genital, for the men, we will have maybe infertile because of obstructive azoospermia is common, and sometimes vas difference will be absent, and sometimes the testicle won't descend down, it will stay in the abdomen. We can fix this in the surgery, by the way. Women will have reduced fertility because of the viscous cervical mucus can obstruct the fertilization. and we will have menstrual abnormalities, for example, amenorrhea, and delayed development of the secondary sexual characteristics. We will do a newborn screening. Like in some countries, like for example in America, it's mandatory to do this newborn screening, and for actually CF, it's mandatory to do it for CF as well to check if the baby have it or no. So we'll do a sample collection in the first 24 to 48 hours. We'll do some tests, for example, immunoreactive trypsinogen, which is if it's normal, CF is unlikely. If it's elevated, CF is possible. We can do a CFTR mutation testing, and we will do it for the most common CF causing CFTR mutations. So here is how to diagnose a patient with cystic fibrosis. So first of all, why did we suspect cystic fibrosis in this baby? It's either because if he have a first degree relative with CF, or because he got positive in newborn screening, or he is showing some features of CF. So the first test we will do is the sweat test. So if we get a negative results, CF is unlikely, and we will do look out for another diagnosis. If it is positive, CF is confirmed. If it is a borderline, like between the positive and the negative, we will repeat it. If we get positive, it's confirmed. If we get a borderline again, we will do a CFTR mutation analysis. If we got 2 mutations, confirmed. None, maybe we'll do a CFTR full gene analysis. Or if we got 1 mutation, also we'll do a CFTR full gene analysis. If we got 1 mutation again, status of second CFTR copy. So if no alternation identified, we will send it to a genetic consultation. And if mutation of unknown clinical significance found, we will proceed to CFTR physiologic testing. If we got a positive, then the CF diagnosis is confirmed. For the confirmatory test, we mentioned that we'll do the sweat test, the CFTR genetic testing, the pulmonary function test, and for the pulmonary function test, our findings will be an obstructive pattern. We will have a low ratio, and the imaging and the chest X-ray. We will in the beginning we will see normal like signs, or show some air tapping or hyperinflation. Then we will see obstructive lung disease, air tapping and hyperinflation, reticular nodular pattern, and bronchiectasis. For the management, every patient with CF requires periodic follow-up with a multidisciplinary team for specialized management. So first of all, we will do a preservation for the lung management. We will do that by pharmacological and non-pharmacological interventions, and try to prevent any kind of infection to reduce the exacerbations. And we will do optimization for the nutrition to solve the problem of the malnutrition. So, also some patients will get benefited from the CFTR modulators. They will be good for them. So, so for the pharmacological treatment, high-dose ibuprofen can slow the progression of the lung disease. Bronchodilators, SABA or LABA, will be also good. The other drugs are not confirmed yet that are good for it, but sometimes they use it, like the corticosteroids, for example. Insufficient evidence, not routinely used. For the non-pharmacological interventions, we will do airway clearance techniques, like some physiotherapy, like chest compressions or something, and half coughing exercises. To CFTR modulators, they are relatively new therapy for long-term management of the cystic fibrosis. It is used with the CFTR mutations AF508 and G511T mutations, only for those. So they will have like 2 types of them: potentiators and correctors. Potentiators will increase CFTR CL channel gate opening and conductance. The correctors will improve protein folding, and we will get the CFTR protein to the cell. And so we will use combination therapy. We will give 2 or more types of the CFTR modulators to get a better function. Additional measures. Oxygen therapy is good for like the patients with chronic respiratory insufficiency, and sometimes we know that the main problem for death for cystic fibrosis is the lung disease. So double lung transplant will also be an option. Complications. The gastrointestinal, we also already mentioned the mucomelia. We spoke about everything about it. If you need to more information, maybe stop the screen and read it. The treatment for it is enema with a contrast agent and surgery in some conditions if we have intestinal perforation or volvulus. Respiratory, we can have, like, these are the complications. So we can have allergic bronchopulmonary aspergillosis. About 10% of people only get it, or emphysema pneumothorax pulmonary. This is a complete revision for everything we mentioned. Like, for example, osteoporosis, we can have delayed puberty and infertility, nephrolithiasis in the kidney, abnormalities in the bile duct. In the lung, we will have obstructive lung disease, nasal polyps, salty sweat, pancreatitis, and what do you call it, we'll get the diabetes from it as well, rectal prolapse, and digital clubbing, and we spoke about everything here. I think that's all actually. Thank you so much for watching. I hope you found this lecture useful. Have a great day. Goodbye. Clear the airways.